introduction. At the outset, I would like to thank the organizers of the symposium, Indian Society of Thyroid Surgeons, ISHNR and GIC family, and special thanks to Dr. Diva Shah for the opportunity. Today my topic is going to be on thyroid imaging risk stratification. I'll be covering TIRADS in detail, and rest of the we'll be looking at ACR TIRADS chart, what is some things in TIRADS beyond the chart, ATA and other radiology review systems. So before we begin, it is important to know that why we need this session. So thyroid nodules are having a high prevalence in the common population, with approximately 67% people in the general population having thyroid nodules, most of which are benign. But our emphasis is on picking up those 7 to 15% nodules which are malignant. Though most of the malignant nodules tend to be differentiated and have a really good prognosis and overall survival. So the overall purpose of these risk stratification systems is to pick up the clinically significant nodules, do the surgery or appropriate treatment at the right time, and not miss out the clinically significant cancer. Because multiple studies across the world in last 3 to 4 decades, we have seen that the incidence has increased, but our treatments have become more aggressive, but the mortality for the cancer has been same across the globe. So that is why ACR TIRADS committee and lot of other risk stratification systems have come up way to pick up and characterize nodule on ultrasound. And just to make it lighter, like during my residency days, the first time I was sitting beside my senior doing an ultrasound, I was being told that thyroid ultrasound, our only role is to tell that whether there is a nodule or not, and if it is there, it is solid or cystic. But we have moved beyond that. So it is necessary that thyroid ultrasound is not equivalent to just picking up nodules and telling whether nodule is there or not. Thyroid ultrasound has evolved way beyond it. So ACR TIRADS came up with this thing so that we can develop management guidelines for thyroid incidentalomas, which we pick up on any modality like CT, MR or ultrasound. Come up with a lexicon with which we can describe all the thyroid nodules on ultrasound, and then on the basis of that lexicon and risk stratification system, we can suggest as radiologists that which nodules would need biopsy and which would need follow-up. So the core summary of the ACR thing is TIRADS. The chart is a no-brainer. It is available on the ACR chart, and to adopt to chart, this chart we need to keep a printout, keep on our systems, ultrasound, and this thing. So we evaluate 5 morphological features on ultrasound: composition, echogenicity, shape, margin, and echogenic foci. And then the different morphological features of all the 5 subtypes, we have to assign the points and then make a total of it. So, with that we get a TR level, and with which our management recommendations are defined. Important point here is that echogenic foci is the only category in which you have to give points for all the things you see. So if you see macro calcifications, you give points for macro calcifications. If you see rim calcifications and macro, then you have to add 1 plus 2 and give 3 points. So this is what is available. It's in the initial days we can just keep a printout, and then over the time it would become a part of our system. So these are the 5 points again: composition, echogenicity, shape, margin and foci. And let us go through the pictorial essay for each category and understand that what each subtype means. So composition can be from cystic, completely cystic, to solid. And if you cannot put it into any of these, then you don't know what it is. If it is a completely calcified nodule, then you assume the composition to be solid and give 2 points. So if we see over here, just a second. Yeah. This is a completely cystic nodule. As all of us doing ultrasound know what a cyst is, an anechoic structure with sharp margins, no posterior features. Next to it is the spongiform nodule. So spongiform nodule, how do you characterize it? So it has more than 50% cystic areas, and usually it represents benign finding, and it should have good sharp margins. But if you have some irregular margins or some calcifications, then you may have to reconsider whether you are truly dealing with a spongiform nodule or not. Then the next one is solid. Again, a no-brainer that it is composed entirely of soft tissue. At least 95% solid areas are there. Cystic areas, if present, would be less than 5%. So that is a solid nodule. I have deliberately kept this thing over here, that the solid nodule, if you see, it's very important to differentiate solid from completely cystic. So solid would be something having hypoechoic appearance. Cystic is something which would be truly anechoic, no echoes inside. So now the nodules which are not cystic, spongiform or solid, they almost completely solid would be solid cystic. So they are in between spongiform and solid, and so these are the two examples of solid cystic, and we have to define rest of the lexicon depending upon the solid component of the nodule. And this nodule, if we see the one on the top right, is a pseudo spongiform. It really looks similar to the spongiform nodule, but here if you can appreciate, the solid areas are really more. So this nodule cannot be characterized as a spongiform nodule. So with all these category, there would be point. So it's important to identify this pattern. The score for each of them, the chart is easily available, that we can every time look up. Next is echogenicity. Again, anechoic receives 0 points, and the highest category, very hypoechoic, receives 3 points. And if you have doubt in which echogenicity it is, then we assume and give it a isoechoic echogenicity and assignment of 1 point. So again, let us review each one of them. Anechoic. Anechoic is one which we assign to cystic or almost completely cystic nodules. What is a hyperechoic nodule? It will have echogenicity which is more than the adjoining thyroid parenchyma. Isoechoic, as the word stands, is equivalent to adjoining thyroid parenchyma. Hypoechoic. So hypoechoic, again, if we see compared to normal thyroid parenchyma, the echogenicity is less, that we call it as hypoechoic. Now, important point is differentiating between hypoechoic and very hypoechoic. So very hypoechoic would be more darker than the adjoining strap muscles of the neck. It would be less than thyroid and less than the strap muscles of the neck. So this is an important point to differentiate hypoechoic versus hypoechoic, very hypoechoic. So with this we go to the next subset, that is the shape. Shape, simple, just two categories: wider than taller, taller than wider. Wider than taller gets 0 points, indirectly or signifying that it is overall pointing towards benignity. And taller than wider nodule will be assigning 3 points. So what is a wider than taller nodule? So wider than taller nodule, the antero-posterior diameter to the horizontal diameter will be less than 1. If in doubt, we can do measurements and assign these category, but more or less it is about a visual inspection of assigning wider than taller. And similarly for taller than wider, like this nodule on the right, where the anteroposterior diameter is more than the horizontal diameter, so the ratio is more than 1. Now, what happens when if it does not fall into two categories? So, if it's a completely round nodule where it is both the distance are same, transverse and anteroposterior, then you assign 0 points and call it not wider than taller nodule. So, points would be 0 only, but definition would be it is a not wider than taller nodule. Next is margins. So, margins again smooth and ill-defined would get 0 points, and ETE is something which would get the highest 3 points. Again, there is one assumption here that if you cannot determine the margin, you call it as a ill-defined margin. So, what is a smooth margin? Uninterrupted, well-defined, sharp edges, spherical or elliptical in shape. Ill-defined. So, you cannot define where the nodule is ending and where is the normal thyroid parenchyma. So, you cannot sharply define, but it's a ill-defined thing which would get a 0 point. Lobulated. Lobulated margins has focal round soft tissue protrusions like this. I've drawn it over here, and that extend into adjacent. So they are round borders, and that lobulations can be single or multiple, and they will be varying in conspicuity and size. As contrast to irregular margin, where the margins are not round but they are like sharply angulated or jagged, and they may or may not clearly extend into adjoining parenchyma. Again, they can be present only in some part of the nodule. So, for any nodule, it is very important for us to identify and assess all the margins of the lesion by rotating our probe in all the angles. The ETE. In this section of margins, ET is something which gets 3 points, and it is very important to correctly assign ETE because it gets a very high score and we don't want to again do unnecessary biopsy. So if a thyroid nodule is just abutting the capsule, then you can mention it, but unless there is clear-cut invasion into the adjoining parenchyma, we will not call it as ETE, because at times ETE assessment is a little difficult on ultrasound. So just bulging into the adjoining structure is not equivalent to ETE. Echogenic foci. Again, this is the most important category because here whatever features you identify, for all of that you have to apply points. So instead of choosing from one, you have to choose for all that are applicable. So these are the subcategories: large comet tail artifacts, macrocalcifications, rim, and punctate echogenic foci. Large comet tail artifact, this is what you see. There is a nodule. It has reverberation artifacts, echogenic. It is an inverted triangle, and as you go deep into the tissue, it will become narrow, and it is more than 1 millimeter in size. So what happens that if at times you have doubt, you may have to actually zoom in the image and measure whether these artifacts are actually more than 1 millimeter or not. If not, because then they may mimic echogenic foci. Macrocalcifications, as the name speaks for itself, they are large, and because they are large and dense calcification foci, they will be associated with these posterior acoustic shadowing. The third category is rim calcifications. So it means there is calcification along the periphery of the nodule. It may be complete or interrupted. And again, if we go back to the previous slides, we had discussed that with rim calcifications, it may be difficult to characterize the nodule composition, and then we presume and give it 2 points as solid. Punctate echogenic foci. Again, this is the category which receives highest 3 points in this, and very important to correctly assign these categories. So these are dot-like foci less than 1 millimeter in diameter, but they may occasionally have small comet tail artifacts, and that's why it's very important to differentiate from the benign large comet tail artifacts. So punctate echogenic foci, like what you see over here, these are the true punctate echogenic foci, and occasionally the normal thyroid gland may have these dots and dashes like appearance, which is just the normal artifact and appearance. So we call punctate echogenic foci when they are only visible within the nodule and explicitly visible. Not if it's similar to the only adjoining thyroid parenchyma, don't overcall punctate echogenic foci. So these are the 5 categories, and then how you do the detailed assignment. So you should have a good high resolution transducer. The presets should be set properly for the thyroid, like as we have for all the things. For MSK we have different, for breast we have different. Before scanning, we have to assess for any priors. We evaluate and scan the entire gland before we actually start documenting. And we take volume of the thyroid gland with 3 orthogonal measurements, followed by measurement of the 4 suspicious nodules depending upon the composition and all the other morphological features which we just reviewed. So how to measure the thyroid nodule? So the important point is that first we take the transverse plane of the nodule. The longest width of that would become the side to side measurement, and then 90 degree to it. So this would be the roughly the plane. So this would be your side to side measurement, and 90 degree to it is what we would take as a antero-posterior measurement. And then you turn your probe 90 degree, take a longitudinal view, and then take the maximum measurement in this plane. After this, all this we'll have to report properly in our documents. This is the TIRADS template which is available on the website, including all the features which we have discussed. It is available on the TIRADS website, and then you take 3-dimensional measurements of the gland, overall description of the parenchyma, and maximum 4 or maybe a 5 or 6, but not more than that. So the 4 most worrisome nodules is what you formally document. So this is how you, I have modified the reporting system as per my convenience, and because we have packs, I do some diagrammatic representation on paint so that the diagrammatic report always remains in the system. This is not part of the TIRADS lexicon, but this is one very important thing for thyroid ultrasound. So I just thought of mentioning it over here, that we should always look for aberrant origin of right subclavian artery. While we are scanning, we always look for the nodes in the neck, and so always try and assess for the junction of common carotid artery with the subclavian artery, because if this you cannot identify, there are high chances that we may be dealing with an aberrant right subclavian artery, and an aberrant right subclavian artery is associated with a non-recurrent laryngeal nerve. So if this is not identified, higher chances of the nerve being injured during the surgery. So this is the short video I would like to demonstrate. All of must have seen it once at least, that this is the aberrant origin of the right subclavian artery, and this is the common carotid artery. We cannot identify junction of this. I didn't have the ultrasound clip for this patient, and this was in this case intraoperatively there was this non-recurrent laryngeal nerve. So this, if you can appreciate, is the trachea, and this is the non-recurrent laryngeal nerve. So non-recurrent laryngeal nerve would have a horizontal thing coming from the vagus nerve directly, as contrast to the normal recurrent laryngeal nerve, which would have a vertical orientation. So all of us should start looking for this aberrant origin of right subclavian artery, and I'd been looking at it since years and fortunate enough to find one case, and it actually changed the management that the nerve could be actually preserved during the surgery. So after everything we have done, reported and assigned the points as per the chart, we have to assign the categories. Again, all this is completely available, and the cutoff criterias which are available, that for TR5 you FNA at 1 centimeter is all on the basis that the probable at least 20% chances that a TR5 nodule would be malignant. For TR4 you FNA at 1.5, follow up at 1, and for TR3 you do FNA at 2.5 centimeter and follow up only if it is more than 1.5 centimeter. So how do you follow up? TR5 is 5, so you follow up annually for 5 years. For TR4 nodule, the 4th year goes out. So TR4, 4th year, 3 and 5 years. And for TR3, the year 2 and 4 goes out, and you don't need a follow up for TR1 and 2 nodules. So growth, how do you define growth? So at least 20% increase in the nodule dimension or 50% increase in volume. If there is no growth over the 5 years, we stop following, label them benign. And if there is increase but it is still below the FNA criteria, you keep on following those nodules. But if it crosses the FNA threshold criteria, then you do an FNA. This is another alternate chart available to approach it, that if you have cystic or spongiform, you assign 0 points. And for this, so there are 2 types of chart available. We can adapt depending upon how convenient it is to us. So beyond the TIRADS chart, here there are certain questions which I would like to cover, that where you cannot apply TIRADS: when it is a FDG avid nodule, when there are associated suspicious cervical nodes, when there is a parathyroid adenoma where patient is already going to undergo under the knife, so it's better that a thyroid nodule is also worked up and treated. For nodules which are adjacent to recurrent laryngeal nerve or trachea, because this is the location of recurrent laryngeal nerve. So any medially placed nodules, it's always important that they are dealt with better, because they are near the critical structures and we can't have a follow-up in that. Symptomatic nodules, and in those with high risk history of MEN type 2 syndrome, radiation in childhood, or family history. So certain questions, that which is the nodule you decide for management. So it's the largest dimension. Then is there a size beyond which you cannot characterize the nodule? So yes, it primarily depends upon the how good your machine is, what is the build of the patient. But yeah, less than 5 millimeter solid nodules or cystic nodules less than 2 to 3 millimeter, it's better to just leave them, because you cannot really characterize them. And in a mixed solid and cystic nodule, this point I'm covering again, that in a mixed solid and cystic nodule, the margins is what you see of the solid component and not of the entire nodule. But within the nodule also, eccentricity is important. So if you have a solid cystic nodule with an eccentric component, then again that is a little alarming sign. PET positive nodules, very common. PET we are doing in and out even for the early stage cancers, and then we pick up lot of these nodules. But yes, PET nodules anything about 1 centimeter, irrespective of TIRADS category, please do an FNA. And if a nodule has been previously biopsied and now the patient has come to you for follow-up, then what you do in that cases? In that cases, TIRADS has the present limitation that we don't know how to handle those nodules. But you do a formal TIRADS reporting and then say that your management should be guided by the previous FNA report and the clinical symptoms rather than purely on the basis of TIRADS. So I know I'm crossing the time, but I'll just quickly cover some other risk stratification nodules. The most common is the ATA, because the ATA is a clinical society and they have a little different this thing, and they found that there are some limitations of ACR TIRADS. And so even in 2025, they're going to come up with a new probable sonography based system. The previous 2015 one was again a pattern based thing. Here there was no point, but you try and see that it falls into which pattern, and then for each pattern there is a cutoff criteria, and then you suggest the biopsy. So they are going to come up with a new sonographic pattern. Already the ATI guidelines for differentiated thyroid cancers are out, but yeah, this new draft is in the pipeline. And why they are coming up with this is that they are telling that presently whatever ACR TIRADS is telling the risk of malignancy and the actual thing, there is some discordance. So meanwhile they want to come up with their own guidelines, and then it does not take into account the prior FNA and the high risk history. So this is why ATA has come up with guidelines which will be incorporating all of these things. And meanwhile, we might have a newer edition of ACR TIRADS also after a decade. So this is what they are going to. Okay, yes. So again, if I have to summarize, there are a lot of other things, but ACR TIRADS is something which has a good balance between sensitivity and specificity. And overall, it is important that we incorporate one of the risk stratification system. ACR TIRADS is what is the most easiest for us, and it would lead to a better explicit communication with the clinicians, and rather than having vague reports and telling that it is just solid or cystic nodules, our reports would make more sense. Thank you.
Thank you so much, Dr. Amee, for a nice explanation in short span of time. Any question from the audience? Yes.
Thank you. It was a great presentation. Definitely. Not questions, but one or two comments. That in TIRADS 4 and TIRADS 5, there is a size criteria to guide for the FNSC. But just wanted to, I think, clarify, and you may agree with me, is that if there are multiple nodules, TIRADS 4, TIRADS 5 in both the lobes, even going out of the size criteria, you will try to FNSC them because there are multi-nodularity in that. So the chances of malignancy increases, and chances for the surgeon to operate that thyroid increases. Second thing is the where the nodule is in the thyroid. A well-centered nodule in the thyroid, you will like to observe. Surgeons and the new guidelines which are coming for the surgical management of thyroid also says that those are the nodules which are safe to observe. But those which are going to the periphery, which may in future go for extrathyroidal extension, or those who
have anything about the location of the nodules.
Right.
So future, the proposal is that even the location where it is in the gland is that what they're going to incorporate in the TIRADS category, which is the present limitation, because it was the first edition of TIRADS.
Right. Thank you.
Thank you, sir.
Amee, one question. We follow the ACR category.
And not the high risk category. So high risk patients, pediatric, PET positive, is where ATA guidelines would be more beneficial.
Better. And last question, suppose in most of the, I observe one thing, few radiologists from the periphery, they generally deny of taking biopsy or FNSC from the thyroid. So is it the same, everything is same as compared to other, we can take even a small nodule
doing
true cut
PGR
biopsy
and everything. So even if it is going to cause hematoma, FNSC will cause it, so even biopsy can be easy.
And I think we